Hello, my name is Pablo Kong. My topic is Adjuvant Sunitinib in high-risk renal cell carcinoma after nephrectomy. Definition: renal cancer constitutes 2 or 3% of all malignant pathologies of this clear cell renal carcinoma, correspond to approximately 85% because this histopathological TP is resistant to chemotherapy. New molecular used for treatment worldwide, called therapy target, with significant results of progression-free survival and overall survival. Sunitinib market has Xutent is a small molecule administered orally with multiple target sites, constituted by receptor tyrosine kinase. This inhibitor was approved by the FDA for treatment of carcinoma, imatinib-resistant renal cell, and gastrointestinal stromal tumors.
Here's the background. About 15 to 20% of all RCC patients will present with high-risk local regional disease, so stage 3 disease, where the 5-year overall survival will be 50 to 60%. And you all know this, and you see these patients. And we have therapy that's proven to extend overall survival in the metastatic population, so VEGF TKIs, Sunitinib, Pazopanib, Cabozantinib, Axitinib, Sorafenib, all with proven overall survival advantage. So in oncology, the standard paradigm in advanced disease is prove a drug in the metastatic setting, usually last line, and then start moving it forward. First line therapy, adjuvant therapy, neoadjuvant therapy, with the general belief that if something is beneficial in the metastatic setting, it should be beneficial in the adjuvant setting. And of course, the point of adjuvant therapy is to improve cure rates. It is conceptually, what we're trying to do is treat micrometastatic disease to eradicate that last little bit that wasn't removed surgically and improve the cure rate in doing so. And this is a well-established paradigm in any number of malignancies. Colon cancer, breast cancer, lung cancer, this is all standard of care. Having said that, the fact of the matter is that it is not automatically true that what works in the metastatic
2. Application in medicine. Sunitinib, a vascular endothelial growth factor pathway inhibitor, is an effective treatment for metastatic renal cell carcinoma. We sought to determine the efficacy and safety of sunitinib in patients with local regional renal cell carcinoma at high risk for tumor recurrence after nephrectomy. Sunitinib was the first drug to be simultaneously approved for 2 different indications of both types of cancer and is currently being studied for treatment of many others. 3. Pros and cons. The safety profile of adjuvant sunitinib was consistent with the broad experience observed in patients undergoing treatment for metastatic renal cell carcinoma. The rate of discontinuation because of adverse events among patients in the sunitinib group, 28.1%, was higher than that reported in the pivotal trial, 8%. Comparing sunitinib with interferon alpha in patients with metastatic renal cell carcinoma. In our trial, skin toxicity, palmar plantar erythrodysesthesia, hypertension, and fatigue were among the most commonly reported adverse events of grade 3 or higher in the sunitinib group. Likewise, these events are commonly reported in sunitinib trial involving patients with metastatic disease. However, in our trial, skin toxicity of grade 3 or higher was more frequent among patients receiving adjuvant therapy than the others with metastatic disease, 16% versus 5%. Overall, these results are consistent with the observation that although the type and incidence of adverse events may not differ greatly between these 2 patient populations, the event may be less acceptable among patients who have undergone nephrectomy.
I present a phase 3 study comparing an anti-angiogenic drug, Sunitinib, compared to placebo in adjuvant setting after nephrectomy for high-risk patients' risk of recurrence. So RCC is a relatively frequent tumor, more than 300,000 patients worldwide. And the problem is any tumor type that when you have been at surgery, you may have risk of recurrence. It is known that you can achieve that in breast and colon cancer, but we don't have that in renal cell carcinoma. We had drugs like Sunitinib, which is very efficient in metastatic renal cell carcinoma, and it's the first-line standard in every guidelines worldwide. And the question was, if you give this drug to the patient that just has nephrectomy, do you improve something, which is less of recurrence? So the study was designed to compare what we do usually, which is placebo, to the Sunitinib standard way to give the drugs to these patients for 1 year. So 615 patients were included in the study, randomized 1-to-1 for 1 year, and after we look at what is going to happen. And it's clear that the drug gives an advantage in disease-free survival from 5.6 years to 6.8 years. The p-value is 0.03, meaning significance. And also, when you look at the curves, there is a divergence that came early and go for a longer period of time, meaning that the hazard ratio is 0.761. That means that it's significant. And the increase also...
4. Issues apply in Ecuador. Sunitinib, a tyrosine kinase inhibitor, is part of the era of targeted therapy available in Ecuador, and despite not belonging to the national cadre of basic drug, the oncology service of the Carlos Andrade Marin Hospital, through a special procedure of purchase, can be purchased for each patient. 5. Conclusion. Among patients with local regional clear cell renal cell carcinoma at high risk for tumor recurrency after nephrectomy, the median duration of disease-free survival was significantly longer in the Sunitinib group than in the placebo group, at a cost of a higher rate toxic event.
Hello, and thank you for joining this OncLive peer exchange titled Therapeutic Sequencing Strategies for Advanced Kidney Cancer. Outcomes for patients with advanced renal cell carcinoma have been significantly improved by the availability of molecularly targeted therapies and now immune oncology-based regimens. However, proper selection of appropriate therapy and management of toxicity remain challenging for oncologists, particularly with availability of exciting new therapies and new combinations. Moreover, high-risk localized disease represents an ongoing challenge, with high recurrence rates and poor survival after nephrectomy. In this OncLive peer exchange, I'm joined by a panel of leaders in the field. We'll be discussing new data from the GU ASCO 2018 meeting, and we'll discuss how and when to use available therapies based on new data. Oncology at the John Theurer Cancer Center at Hackensack University Medical Center in Hackensack, New Jersey, and Dr. Bradley McGregor, an instructor in medicine at the Harvard Medical School.
Tissue or kidney cancer involving the local regional lymph nodes. So I think those are the patients at high risk of recurrence.
Okay, and that's roughly what percentage of patients do.
Thanks for your attention.